liver disease. I hope I get this right.
That's right.
The Antiviral Association, it used to be the International AIDS Society, and the Infectious Disease Society of America. And they have a living document, which I suspect the site will be on some of these slides, that you can go to. They have weekly conference calls. So this document is as up to date as you can possibly get on the subject of hepatitis C. So long story short, we have a real expert here, and he's a wonderful person, has demonstrated leadership qualities in so many ways. So it's a treat to have him here, and then tomorrow we're going down to Salem for the Infectious Disease Society of Oregon. The brochures are outside. I'm putting in a plug for that if any of you have the time to join us tomorrow. I also want to put in a plug for Dr. Sag's book. It's called Positive. It's available on Amazon and God knows where else. It's sort of a lay perspective on infectious disease, and in particular patients that have changed lives as we have dealt with their AIDS and other chronic infectious diseases. So with all of that, Dr. Sag, teach us about hepatitis C. I told Mike I wanted to give one statistic from the Oregon Health Division. Look around the room. We have about 50 people more coming. The Oregon Health Division says 1 in 32 Oregonians are infected with hepatitis C. Michael?
Thank you. Thanks, Dave. It's great to be back. And I'll just start with the thesis, which is on this first slide, which is hepatitis C is at a point where we all need to pitch in, meaning internal medicine, family medicine, primary care docs really can and should be treating hepatitis C in routine practice. And hopefully by the time I'm done with this talk, you'll see that not only is that true, but it's relatively straightforward to do. It's not all that complicated. So let's go. So these are my disclosures. Dave mentioned the SSALD, IDSA, ISUSA, Alphabet Soup guidelines. And the website is right here. It's just hcvguidelines.org. And if you ever have a question about anything, that's just the perfect resource, because it's a living document. It would be silly to put this in print, because by the time it got published, it would be, by definition, out of date, because things are moving so fast. So we're going to talk about genotypes of HCV, how they relate to treatment, how to stage HCV and why that's important for treatment, and describe some of the emerging treatments. I don't expect you to walk away from here necessarily quoting any study or any drug in particular. I think you can go back to the guidelines and get all that. What I'd like to leave you with is a gestalt, a sort of a feeling that this is A, really cool, that we're curing hepatitis C with all oral therapy, and 2, this is something we all should do. So I don't have the little keypads, but just to yourself right now, answer this question. You'll know how you answered at the end. Which most accurately stages liver fibrosis? For you GI folks, this is like falling off a log, but for everybody else, it's like reaching back to medical school or training and trying to remember. There'll be several moments like that during this talk, so fasten your seatbelt on that. What % of patients with chronic hepatitis C develop cirrhosis over 30 years? Is it all of them, a few of them, somewhere in the middle? Progression of disease to chronic cirrhosis, which is end-stage liver disease ultimately. And then which is the most common genotype? And perhaps some of you walked in the room not even knowing there was more than one genotype for hepatitis C. That's okay, but these are the major 6. And one of these is the #1 in the US. So this is the talk. This is what I'm going to go through. And you go, how are you going to do that in 45 minutes or so? But we will. It goes fairly quickly, and hopefully this will keep everybody oriented. So let's start with epidemiology. First off, let's look at the history. I see a number of other people in the room who've got gray or thinning hair, and those of you who trained with me in the 70s and 80s know that this entity during that time was known as non-A, non-B hepatitis. Very common cause of liver transfusion complication, and in essence, by 1989, it was discovered as hepatitis C. Through the 1990s, treatments started to emerge, one of which was interferon, which is, as you know, if you've ever given it to anybody, it's incredibly toxic. It makes you feel like you got the flu for 2 or 3 days after a single injection. And then a drug that those of us in the AIDS field know, because it was a drug looking for something to treat, called ribavirin. And this company out of Arizona was pushing for it to work, and it just never did against HIV. But remarkably, when paired with interferon, worked really, really well, at least reasonably well, for hepatitis C. If you ask anybody what's the mechanism of that action, no one has a clue. But I can tell you that it does work, it does help interferon, but no one can tell you why. By the late 1990s, 2 good things happened. Interferon became so-called pegylated, put with polyethylene glycol, and it could be given once a week instead of daily. That helped. And also, a really critical thing from the basic science component, something called a replicon was created. And a replicon is a way of in vitro testing hepatitis C against small molecules. And that's the beginning of the revolution. That was the sounding of the alarm. Because now everyone could use their technology to develop small molecules and know within days whether this thing had legs or not and to move forward with. I might add as well, from an HIV perspective, all this incredible acceleration of knowledge and improvement in outcomes can be attributed to the war on AIDS. Because what we learned in drug development, all the way from how to design molecules and how to test them and rapidly determine their effectiveness in vivo, plus regulatory approval. The FDA, the lessons they learned in accelerated approval and parallel track and all those things were just copied and pasted onto HCV, and that's why it was a perfect storm for this revolution. But the replicon was the beginning, and the rest I'll sort of go as we'll flesh out from there. Worldwide, 170 million people are estimated to be infected with HCV. In the United States, it's about 3 to 4 million. I feel like a weatherman here, hot front coming in from Africa, but you can see, relatively speaking, where HCV is. And then to get to that genotype question, as I mentioned, there are 6. And in the United States, you can see it's predominantly red. So answer to one of those questions, genotype 1, or number 1, is the one that is the most prevalent. And fortunately, a lot of the single direct-acting agents, small molecules, are active against genotype 1. Another thing you should know about genotype 1 is it has 2 subtypes, genotype 1A and 1B. How do you keep them straight? A equals awful. B equals better. Okay? So as you look at the data as it comes to you, 1A is typically less responsive, especially to interferon-based regimens, than 1B, but both of which do have impact on which direct-acting agents you use, and in particular whether or not you have to use ribavirin along with the treatments. That is, for 1A, for several regimens, you really have to have ribavirin still in the mix, although interferon is now out. Genotype 3, the green one, you see some in the US, and other areas of the world, a lot more green, as you can see, like in India. Genotype 3 is currently the one that's giving us the most problems with direct-acting agents. But as I'll show you, improvements coming very quickly. And literally on Friday, I think several of you, especially if you're in liver or GI, will be going to the AASLD meeting, which will be in San Francisco, just up the coast. And we'll hear more about all this. Well, the incidence of hepatitis C dropped dramatically in around 1990. Why? A test. So we started screening the blood supply. And that sort of tells you the relative importance of transfusion-related transmission of hepatitis C. Stop that and it starts to go away. The current most active modes of transmission today, intravenous drug use and needle sharing, to some degree sex, but much, much, much less than HIV. It can happen. It seems to be happening disproportionately among young gay men. And there are even people who have been cured of hepatitis C in that population who then get reinfected, not relapse, they get reinfected with hepatitis C. Not common, but it happens. We'll talk about that as the talk goes on. And just like, and first off, I don't know how many of you feel like you kind of know HIV pretty well. If you do, you're 2 orders of magnitude ahead of the curve in learning about this. Because as we go through this, the parallels to HIV are striking. IV drug use, blood transfusions, sex, transmissions, right? Not so much mother to child in HCV. It can happen, but it's not all that common. It can happen. Hepatitis B, much more likely that way. But in this case, just like HIV, a lot of people who have it don't know it. And they won't know it until they get tested. In the case of the so-called birth cohort, which are the people born between 1945 and 1965, that's where the biggest wave of infection is, prevalence-wise, in the United States today. And it's disproportionately, just like HIV, disproportionately minorities, black population, especially in the southeastern U.S. I was mentioning to Dave earlier, though, because of the recent surge in heroin use, et cetera, in a lot of the pockets of the country, there's now an emerging new epidemic of hepatitis C in white young people who are using IV drugs. In our emergency department, 6% of people walking in the door between the ages of 18 and 29 are hepatitis C positive. 6%, and they're almost all Caucasian. So it sort of tells you that it's bubbling out there, it's still happening. Natural history. This is complicated but simple, if that makes any sense. The slide looks complicated, but if we walk through it, it'll make sense. So somebody gets exposed and infected. 15% of them clear the infection. That's it. They cured themselves. Their immune system wiped it out. You know that they were infected because they have antibody positive, but when you check for HCV RNA, undetectable. That's that group. No need for treatment, no need for any long-term follow-up, not at risk for anything bad, done. Of the 85 or so percent who have chronic, lifelong hepatitis C replicating in the liver, about 80% stay stable. I think that number is more like only 70%. And 30% over the course of 30 years will go on to develop cirrhosis. That answers that other question that I asked earlier. The problem is, we can easily tell who these folks are, but we can't predict out of those who are chronically infected which ones are or are not going to develop cirrhosis. We know that heavy alcohol use on top of HCV speeds progression to cirrhosis, for sure. Co-infection with HIV tends to speed things, but it's not a given. It's not a guarantee that those things will happen. So what it means is that of our populations that we identify here, we have to continuously screen them or know at least where they're staged in terms of the degree of liver fibrosis. The answer to the other question I started with is, what's the best test? A liver biopsy. Makes sense, right? You get a piece of tissue, you look at it. But there are newer tests I'll talk about in a second that are really superior, not superior, superior in terms of risk and cost, and give you virtually the same information. We'll talk about that. But once somebody gets cirrhosis, bad things happen. Some only slowly progress, but 6% of that group per year go into end-stage liver disease, decompensated cirrhosis, and 4% develop hepatocellular carcinoma. Contrast this with hepatitis B, where in HCV, only those with cirrhosis, for the most part, develop hepatocellular carcinoma. HBV, it's not related to liver fibrosis. So if somebody with a normal liver on biopsy could ultimately, with HBV, develop hepatocellular carcinoma. Those are just important points to keep in mind. But the treatment for this ultimately is transplant, and most people, unfortunately, go on to die. And this is the time frame that this progresses. I think this is more or less just reiterating, but if we look at the timeline from the birth cohort, people born between 45 and 65 infected in the 70s and 80s, for that 30-year period to happen, you're going to start seeing this rise in deaths and complications all along the way. And that's predicted to be out by 2030. If we didn't have these treatments, this would be the natural history. With the treatments, we hope to totally bend these curves downward, and I think we can do it. But that's where all of us come into play, because there's not enough ID docs, there's not enough hepatologists, not enough GI docs. It's going to take all of us. That's the theme of the talk today. This is just an example of how HIV co-infection accelerates mortality in those who are infected with hepatitis C as well. So the blue is those HCV mono-infected, not co-infected with HIV. And their mortality at 1 year is about 25%. 40%, and about half are dead in 5 years once they develop decompensated liver disease. But if they have HIV on top of that, those survival rates are worse. So Oh, no, and every person with HIV ought to be tested for hepatitis C and treated and cured of that if they're in your HIV clinic. Well, how do we stage? Well, this is a listing, liver biopsy gold standard, but there are ways you can do it. Everyone says a platelet count of 150 is normal. Well, sort of. If you got a platelet count of 140, that really isn't normal. And a lot of us just sort of look at the hemogram, oh, it's normal. But in this case, no, it's not. You get a platelet count less than 100, really abnormal as far as predicting cirrhosis. But so there are ways you can look at APRI score, which is a platelet AST sort of ratio, something called FIB4. These are things that you can learn about later, but they are indirect markers. FibroSure is kind of a test that takes 5 or so different markers, puts in a fancy algorithm, and gives you a relative risk of cirrhosis being present or not, and these other things. But what's really come along in the last 10 plus years is transient elastography, which is done with this. And we have one in our clinic. It's all over Europe because they got approved in like 2003 or 4. We just got approval in the US for use of this device around 2012, 2013. And so it's an expensive machine, but I think in my practice, it's enormously helpful. So this is how it works. You have this machine, and it's got a little transducer, and you put that right here at the bedside. We do this right in the clinic, right in the mid-axillary line between some ribs. And you hit that little button with your thumb after you get in the right position, and it sends a wave, like kind of a shock wave, through the liver, followed by a detection wave. And this is just basic 101 physics. If the liver is nice and soft and spongy and not scarred, the wave takes a little longer to go through. If the liver is scarred and hard like a rock, the wave zips through. So in essence, what it's measuring is the speed with which the shock wave travels. And then the computer part of the device calculates that, looks at the speed, and then kicks out a score in kilopascals. That's a term, even in physics, I don't remember, to be honest with you. But it has to do with relative Okay, I'll be right back. So it's relative sponginess. So the lower the number, the more spongy, the higher the number, the more stiff. And there are cut points. And here they are. Basically, a normal liver is somewhere between 5 and 7. This is the Medivir scoring. F4 equals cirrhosis, F3 is severe fibrosis, et cetera. If you're in somewhere between 9.5 and 12, that's a lot of scarring in the liver already. Anything over 12.5 is just frank cirrhosis, and the correlations are really very strong with this. I've had patients with up to 50 kilopascals who, by that time, mostly have decompensated cirrhosis, so you hardly even need to do the test. But you get the picture. So this, before I can even walk in to see them, as they get their vital signs on a first visit, they'll get this test done, and I'll know walking in the door what I'm dealing with before I even say hello. It's pretty cool. So this is just internal medicine 101, right? Everyone kind of knows this from our practices, but the signs of decompensated liver disease because of portal hypertension, thrombocytopenia because of splenic sequestration, leukopenia, anemia. But it's kind of a clinical judgment. And if you remember the concept of Child's A, B, and C, it's a compilation of symptoms that have to do with ascites, which by definition means the liver is decompensated. Or it could be some degree of mild encephalopathy and that type of thing. That forces you into the Child's B or C category, and by definition, anything other than Child's A is decompensating cirrhosis. So those mortality rates I gave you after decompensation means non-Child's A patients across the board. And we've all seen the patients in flat-out liver failure who are almost orange with jaundice and are flapping and have spiders and GI bleeds, and we've all been there. But those are pretty obvious, right? The more subtle ones are mild ascites or some degree of encephalopathy. The problem with Child scoring, though, is that with a Child's classification, it's clinical. And so some people, to get liver transplants, you have to go on a list. And they would score them, but clinicians would be generous, let's say, in the degree of encephalopathy score. So they were having problems. So they created this MELD score concept. And it's what's used for for liver transplants, anything greater than 15 on a MELD score, and you can just get your little calculator, put your numbers in, you don't have to memorize the thing, the actual formula, but the bottom line is, anybody who you're taking care of is an internist, or an ID doc for that matter, who has a MELD more than 11 or 12, send them right away to hepatology so that you're co-managing them. You don't want to be in the position of managing somebody with potential decompensating liver disease. That's for the specialist, and I mean the liver specialist. And the rest of the folks we can manage, but this is the key take-home point, that we have to draw that line where we're not out there, because decompensation can happen overnight. And the best way we see it, the most common way we see decompensation is SBP, right? Spontaneous bacterial peritonitis. And we might think, well, they're going to show up with fever and belly pain. No, most times they don't. It's a subtle sort of loss of awareness or dementia or just kind of lack of energy. Any change in clinical condition, if they have ascites, when you admit them to the hospital, before they even leave the ER, stick a needle in their belly, draw some fluid off, and see if SBP is present. Because if you miss it and it's there, it could be fatal. So that's one really important take-home point for everyone. This is what the MELD score is based on, creatinine, bilirubin, INR, and you can see that it's fairly objective, right? There's not a little bit of a cephalopathy or ascites. And typically, depends on where you are. In my neck of the woods, a MELD score of about 23 is required for someone to get a transplant, because livers are short supply. If you're in New York, you need a MELD score of about 32, 33. I don't know what it's like here in the Pacific Northwest, but it varies based on the region and the distribution availability of livers. And then you can see here's MELD score 15. This is 3-month survival, 3 month. And once you get above 20, that's badness. Another thing I just want to review quickly is just kind of recapping, is that when anybody has a GI bleed from varices, that is associated with about a 30% mortality. A lot of people die when they have just a simple variceal bleed, so we've got to prevent that. So another reason to take your patient who's got any degree of cirrhosis and get them to a GI doc, even if they don't have decompensated disease, is to get them scoped. And if they have varices, they can be banded, literally a rubber band's put around it, and that helps prevent bleeding. You want to prevent that. But again, that's another take-home point that we all should keep in mind when we're following our patients. I've already mentioned hepatocellular carcinoma. It's bad. I'm not going to go into treatment because none of us in this room, unless we're hepatologists, are going to be involved in that, or radiology. But one thing I do want to leave you with is a notion of you don't biopsy this. You make a diagnosis from a CT scan. It's one of the few things in cancer where you don't need tissue. And the so-called quad-phase CT or 3-phase, triple-phase, whatever, does this. So what happens is the vasculature of the tumor is so great, on the first pass, it lights up before the liver phase actually happens. And by the time the liver starts to absorb all that, it's cleared. That is pathognomonic. The radiologist in a heartbeat will say, won't hedge. Could be, maybe, rule out hepatocellular carcinoma. And then they'll measure the lesion and tell you the size. If it's over 2.5, that puts them immediately on the transplant list. So now let's segue into treatment. And this is really the meat of the talk. That back story was just to make sure everybody's on the same page about liver disease and what to watch for as you follow patients. But now comes the real meat of the story. HCV is like HIV. It's an RNA virus. It infects a cell, replicates, uses a bunch of sort of host material to do that, and then spits out new viruses. What's different? There's no intranuclear provirus state. What does that mean? You can cure this. We can't cure HIV because of that proviral state. We can stop the replication in its tracks. We can drive viral load to undetectable, but as soon as you stop therapy, because there's residual virus inside the host nucleus of the cell, it can reignite, and then you got your virus back. Here, it's all in the cytoplasm, and it goes. Another common thing, HIV. 1 to 10 billion viruses produced today, every day. Hepatitis C, 100 billion to a trillion viruses produced a day, every day. So when you measure viral load in HIV, it's common to have a value of 1,000, 10,000, 50,000 copies. With HCV, the common viral load is 2 to 4 to 5 million copies per mil. Does that mean anything in your ability to cure them? No, it doesn't. What it means is that when you treat, you can go from 3 billion to undetectable in a week. In a week, not guaranteed, but it happens. Then by 4 weeks, almost for sure, because the replication is just that rapid. And when we give our drugs, they just interfere at these different points in the life cycle and shut it down. It's kind of cool. In fact, it's really cool. So here is the virus. It's 9.6 kilobases. How long is HIV? 9.5. I mean, it's like these things were copied and pasted, this whole story. And they have an area here, not important to remember the numbers or the letters, where a protease works. And they have out here where an RNA-dependent RNA polymerase, if it's HIV, it's an RNA-dependent DNA polymerase or reverse transcription. This is just standard RNA to RNA. But guess what? Nucleoside drugs stop that. Non-nucleoside drugs stop that. So like I said, if you know anything about HIV, protease inhibitors and HCV, they work right here. Not the same drugs, obviously, but the class, the concept of protease inhibition works right here. Nucleoside, nucleotides work right here. Non-nucleosides work right there. And the one difference, but is an important one, is this one area right here of which there's not a good explanation on exactly what it does. It's called NS5A. That's the only letters and numbers I'm going to sort of leave with you to maybe remember. Why? Because the NS5A inhibitors are the anchor to most every anti-hepatitis C regimen moving forward. You're going to hear a lot about that. And when the regimens fail, which isn't all that often, can you get resistance? Mm-hmm, you can. And that would be another time to refer. If you're treating somebody in your practice, internal medicine, and you have 98% of your patients who you treat go to undetectable and stay that way 12 weeks after treatment, you've cured them. That's really cool. I can't tell you how fun it is to tell someone, we've cured your hepatitis C. It's gone, not coming back. But for about 2%, they're undetectable at 12 weeks, but by the time they come back for their 12-week post-evaluation, they've relapsed. And that's when you really want to send them to a liver or an ID specialist, because then we have to potentially assess for resistance. Protease, NS5A, nukes and non-nukes. What happens when you treat? I've already told you, it drops. The only reason I show this slide, this is from the old interferon days. You treat for 48 weeks with this stuff. Can you imagine having the flu for 48 weeks? Horrible. Oh, and by the way, ribavirin, within 1 day or two of treatment, you get a massive hemolytic anemia. So now you have the flu plus an anemia. They usually drop about 2 grams, sometimes more, in 1 to 2 weeks from ribavirin. It's like, the patient, well, do you hate me? Right, what are you trying to do? 48 weeks of that, and we'll talk about it later about the response rates, but the point in here is that some people with interferon never responded at all. They're called null responders. And in the world's literature, they have always, if you had a genotype 1A null responder, their response rates on retreatment were about 5–10% with interferon. Bookmark that when I get to some of the studies in a second. So the prior standard of care, interferon. Look at this. Whoopee. Genotype 1, maybe, for all that 48 weeks of misery, 40% success, especially for genotype 1A. If they're null responders, 0%. The genotypes 2 and 3 responded a little better, but it's still interferon for 48 to 72 weeks. Not good enough. So the current treatments, here they are. And there's more coming. In January, Merck will have its 2 drugs that I'll talk about at the very end. But here they are. And you can tell what they are, whether they're a nucleoside or nucleotide or an NS5A or a protease, by their suffix. All the nucleosides are buvirs. That's the buvir family. All the NS5A are, pardon my expression, asvirs. You can remember that. Asvirs. And then all the proteases are Previrs. If you know that, you can figure out just by the title of the drug what it is. So the Clat-Asvir, NS5A. Desabuvir, non-nuke. Bit-Tas-Asvir, NS5A. Paratap-Previr protease. Do I expect you to memorize that? Hell no. It's just kind of fun to talk about. All right, now look at this. Compare this to what I showed you earlier. This is the beginning of the revolution. So you have a protease, a Previr, with just PEG-RIBA. And all of a sudden, the relapsers are getting 80%, and the null responders even are getting up to 50%. So it shows that this case, a protease inhibitor just added to PEG-RIBA made a big difference, but that's not the story. Look what happens when you get rid of PEG-RIBA. This is sofosbuvir, a nucleotide with a protease inhibitor, with or without ribavirin, for either 12 or 24 weeks. 78% were 1A, and the majority were advanced cirrhosis. By the way, cirrhotic patients are more difficult to cure. Why? Blood flow, right? Going through a scarred liver just can't get in all the sinusoids. It's just all chaotic. You can still cure them. They just have to sometimes give longer treatment. But they're the more difficult to treat. We've got really difficult to treat people with these regimens, no interferon, a little bit of ribavirin. Wow. Wow. Don't need a statistician to tell you this is working, right? And this is just the beginning. So let's take an Asvir, an NS5A, with a Buvir, and see what that does with or without ribavirin for 12 or 24 weeks. Boom. This is intent to treat. This isn't on treatment. This is, you start them on treatment. If they fall off, if they have toxicity, if they don't finish, they're counted as failure. It tells you that the drugs are fairly well tolerated as a group. 12 weeks. And nowadays, one pill once a day for many of these. That's what I'm trying to tell you. This is something we can do. And in some ways, it may be easier than even treating prostatitis, which sometimes can be very problematic to cure, right? Long-time therapy, got to make sure you're not missing something like chlamydia or whatever. This is doable. And it goes on. Here's Ladip-Asvir, an NS5A with sofosbuvir, a nucleotide, with or without ribavirin, 12, 24 weeks, boom. These are the AbbVie drugs that just got approved about a little bit ago. Not important for the numbers. Again, people that are difficult to treat, sometimes relapsers, they're having good responses. The thing to remember about this, and the guidelines will tell you, don't even remember, I'll just tell you about it and you can refresh when you start really doing this, is that for the AbbVie products are not quite there for genotype 1A, so you got to have ribavirin. But when you go to the guidelines and you're trying to decide what to use, it'll walk you through this, so it's pretty straightforward. And so these are the different combinations, NS5A, the Asvirs versus the nukes or the non-nukes, and with or without ribavirin. And this, as of 2015, are the regimens and what they're composed of. Not expect you to memorize this. For all means, I'm not telling you to memorize this. This is just what you get off the website. This is why it's so valuable. www.hcvguidelines.org. Or if you just Google HCV guidelines, you'll go right there. And just, if you have interest in this, you can just stay there and play around for, 20, 30 minutes, and you can learn all you want to know that reinforces. And the difference between treatment naive and treatment experienced, whether you use 24 weeks or 12 weeks, if they have cirrhosis or not cirrhosis. But that's the take-home point. What you need to know is degree of fibrosis, cirrhosis or not, what genotype, 1A, 1B, and whether or not they're treatment naive or experienced, especially in the cirrhotic group. And then if it's genotype 2, it's a different set of drugs. Cirrhosis, non-cirrhosis. Notice the difference in treatment time between those two. And this is a new drug that was just approved over the summer in the United States. It had been in Europe for about over a year and a half. The Clat-Asvir, an S5A inhibitor, with sofosbuvir is really very good for genotype 3, where ledepasvir and sofosbuvir not quite as good here, and so forth. See ya. Bye. Won't miss you at all. There still are a few patients here and there where you might use interferon. I'll tell you, if you're an internist, you won't use interferon. If it's that kind of patient, just refer them to somebody else. You don't want to deal with that. Trust me. And you don't have to, for the most part. Now, if you're paying attention at all to something beyond the Republican debates, right, you're hearing more and more and more and more about the cost of medicine. Hepatitis C has been one of the catalysts. I've got a few minutes, so let me just kind of jump into that. I'll tell you the story of Pharmasset. It's a company out of Emory University and Ray Shinazi. Ray had been involved in the development of 3TC and FTC for HIV therapy. So he's all about antiviral drugs, small molecules. And he jumped in to hepatitis C around 2000 when the replicons came along, and he developed kind of a stable of molecules, the most prominent of which was a drug called Pharmasset 7977. Because he had sold some of these products to Gilead before, he went back to Gilead and I'll make up the date, 2007, 8, and said, here, I'll sell you my entire stable of compounds for $600, $700 million. And they didn't have much proof of concept in humans yet, and Gilead said, no, we got some other things going. So Shinazi said, okay, I'll just keep working it. By 2011, you saw the results. 7977 is sofosbuvir, SOF. See how much often SOF is there? He went back, Gilead bought his stable for $11 billion. Now, you're Gilead, you just got this incredible number of drugs. You got to do some calculus on what you got to charge for that to get your money back. So they get first on the market as far as the all-oral regimens, and the original pricing for sofosbuvir was $90,000 for a 12-week treatment course. And the cost effectiveness actually works. If you do standard cost effectiveness, that turns out to be roughly about $50,000 per quality, which in the United States is viewed as cost effective. But it's expensive. And then they developed ledepasvir, and they pool it together as one pill once a day. And they figured, all right, their earnings, by the way, in that first couple quarters were $2 to $3 billion a quarter. So they made a good decision. So they said, well, we can just throw this together and bundle it and sell it for $90,000 or $84,000 or $96,000. That's 2 drugs for 12 weeks. All right, good. AbbVie comes along, and you think, all right, they didn't spend $11 billion for all their drugs. Market's going to be at play, right? They priced it at $84,000. Merck's about to release, I don't know what they're going to price it as. It's not a free market, folks. We want it to be. We're preached that it is, but it ain't. And I could spend another 3 days talking to you about why, but I'll just suffice it to say it ain't. So, it's a lot of euros, it's a lot of dollars that we're spending on these drugs. If we treated every person in the United States this year, coming in 2016, we would spend something like $270 billion on treatment. And if I got the numbers right, for all medication costs in the United States, we spend about $240 billion in 1 year. We can't afford it. So what are we going to do? All the payers are screaming because we can't afford it, right? Medicare, Medicaid. And they start putting up barriers. Oregon State, right here, did an assessment of all those studies I showed you and rated them as, quote, poor evidence. Everything I just showed you, your state, that organization, some of you may be in that organization, you rated it as poor evidence. Why? Because it wasn't randomized. Well, think about that for a minute. If you were going to randomize to interferon-based regimens for 48 weeks with ribavirin and a known success rate of 40% versus preliminary data that says 12 weeks, hardly any side effects, relatively speaking, and 98% success, you're really going to randomize? Is there equipoise around that question? Hell no. So the FDA said, we'll give you a pass on the randomization, but the Oregon State organization said, poor evidence. really. And the reason they did that is because, as my understanding, they were sponsored by the payers to do their assessment. And so there's this battle between the payers, the public, the patients, the providers. And I have to tell you that even though I'm here enthusiastically encouraging you to get involved in this, once you do, your biggest frustration is going to be with getting medicines paid for. But it's worth it. It's worth it. Because if we hang in there long enough, this flux will equilibrate somehow. I'm not sure how, but I'm just an optimist. I had a book called Positive. So there you go. So the final questions, and I'll finish right on time, about 15 minutes early so we can have some questions, or we can just go get some more coffee. What does this mean? I didn't define SVR. SVR means sustained virologic response. So you've treated someone for 12 weeks. Their virus is now undetectable, target not detected. And you wait 12 weeks post end of treatment, and you retest them. 98% of the time, 95% of the time, it'll still be target not detected. That's called an SVR12. Some of the people relapse in that time. They're not cured. But if they have an SVR12 of target not detected, they are cured by all intents and purposes. Here are the data. So this is just a series of long-term follow-ups, and everyone, if they had an SVR12, also had an SVR48 and also had an SVR72. That's 48 weeks after end of therapy, 72, you get the picture. What does it mean? Everyone does better. Not just do they live longer, but they don't get as much progression to cirrhosis. The HIV co-infected folks do remarkably well in terms of overall survival, right? The 5-year risk of hepatocellular carcinoma among those who are cirrhotic at baseline drops dramatically. Overall survival, this is from JAMA, these are people at SVR on the top. These are people who had relapsed on the top, but those people who had no treatment in the solid line or who were non-responders to interferon, they're not doing so well over 10 years. It's incredible. We really save lives. That's why the cost effectiveness, even at $90,000 per treatment course, is there. On more and more, with SVR, without SVR, hepatocellular carcinoma, with SVR, without for liver failure. Moreover, if you're going to transplant somebody, it's really better to get rid of the virus before you put the new liver in. Why? Because if you don't do that, 100% of the time the new liver is going to get infected. You're still going to have to treat them, but the balance of discussion in the literature around transplant populations, do we treat now or later? And sadly or weirdly, maybe that's a better word, a lot of the transplant hepatologists are saying don't treat them because it'll force their MELD score in the wrong direction. They won't get a new liver. So let them have liver failure. We'll get them a new liver, then we'll cure the hepatitis C. There you go. Future treatments, bye ribavirin. Been nice, not really. And these are some of the things we'll hear about next week. What we're looking for is, Dave quoted this one study, or this one editorial, we're looking for perfectavir, right? Perfectavir. Takes care of all genotypes. Same treatment course for cirrhosis and non-cirrhosis, doesn't matter. So then you wouldn't have to stage, you wouldn't even have to know the genotype. Take perfectavir for 8 weeks, we're going to cure your hepatitis C, and we don't even have to think about it. That'll be easier than treating hypertension, right? So these are some of the newer drugs. Gilead has yet another drug out of their stable that's like ledepasvir. It's another asvir drug. It's just got a name and I can't remember it, but it's 5816. It's pangenotypic, whereas ledepasvir is not. Decladasphere on the market, sofosbuvir, that's that Pharmasset 7977. Here are the two Merck drugs. Tell me what they are. Previr, protease inhibitor. Asvir, NS5A. Good. See? Not so hard. And then the next wave are these different drugs. And it's almost gotten so successful that the drug companies are saying, all right, there's not much of a future here for me. I'm going to move on to hepatitis B. That's also next week's story. So watch this space, as Rachel Maddow sometimes says. Watch this space because you're going to see we're going to start looking to cure hepatitis B next. And that's tougher because in that life cycle, There is something that B has that C doesn't. It's something called closed circular DNA, and that's the bugaboo. It's almost like integrating. We've got to find a way to get rid of that thing, and that's preventing us from curing. We can control hepatitis B. You give tenofovir to an HIV patient who's HBV positive, it knocks the hell out of HBV in terms of replication, but doesn't cure it, and doesn't convert E antigen very much. So those are the things that are happening. I'll summarize by just saying, one, this is really cool, right? This is super cool to think in the last 15 years, and really in the last 5 years, right before our eyes, there's this exploding treatment revolution. And it works. And it's one pill, and it's 12 weeks. And you cure people. You don't just suppress virus, you cure the virus. Two, yeah, there's some nuances, and I hope I did justice to the nuances, not oversimplifying, but it is something you can get your head around if you have the desire, and I hope you do. Because in your stable of patients in your clinic, I guarantee you 6 to 10% of them have hepatitis C. You could refer them somewhere else, but I'll tell you what, there's a ton of joy in them calling you after their SVR12 blood's drawn, and you're on the phone with them, and you pull up the lab and you say, you're cured. I can't tell you that. For an HIV guy, wow, what I would pay, what I would do to have that in HIV. You can do it in HCV. It's really, really fun. So all of us can do this. We can do it now. It takes a little bit of activation energy to learn it. But if nothing else you walk away with, test all of your patients in your panel for hepatitis C. Know who they are, so that when the treatments come along, you can either hopefully treat them yourself or get them to a place where it can be treated. Dave, thanks for having me back. I hope this was instructive, and I'm happy to answer questions. Thank you.
Well, as promised, one has to reflect back to the pre-antibiotic era and the dramatic impact that penicillin and all the other antibiotics had, and it changed our life.
This is going to change our life in terms of managing this huge patient population that's infected. Questions? Yes. Courtney.
Resistance development.
Yeah, so questions about resistance. It happens. Fortunately, most people are cured, right? There's not a ton of evidence that says that there's a lot of pre-existing resistance, so whether or not we'll be testing ahead of time is in flux. I think we might for NS5A, for the Asvir drugs, especially the Merck drug, this Elbisvir. It's hard not to say Elvisvir and go to Vegas or something. But for Elbisvir, it really doesn't work that well when there's a pre-existing, it's just a small fraction. So we might be testing for that. Every person who fails a regimen or has a regimen fail them, we should, before we retreat, right at the time that they're having the relapse, we should go ahead and send off a resistance test. They're available just like HIV. So we're going to have to manage that. And if you really want to be a maven in this, you learn about all that. But if you don't, you say, well, I'll just take care of 98% of my folks, and that 2% I'll send to somebody else. That's fine. Yes?
Do people get reinfected?
Yeah. I mentioned that earlier, but let me go into detail. So let's say you have somebody, you cured them, they have an SVR12, an SVR48, whatever. 3 years later, they come back, and they've got a bump in their liver enzymes. Recheck them for Hep C. Of course, the antibody is going to be positive. You check for the RNA, and it's back with a vengeance. Is that a relapse? That's a reinfection. And when you do the genotype, more times than not, originally, let's say they had a 1B, now they've got a 3. In Indiana, where this heroin epidemic is happening among white men and women, it's almost exclusively 3. It's a lot of 3, not exclusive, but it's a lot of 3. That's unusual. But it just goes to show, you pick it up from a single person, you don't pick it up from a population, right? So you share a needle, 3 is prevalent, there it goes, it just whoosh. So yes, it can. And then the other population besides the drug-using population are especially gay men, and I think it has to do with receptive, unprotected anal intercourse, and because of trauma during the encounter, et cetera. But it's not easily transmitted sexually. It's just not, it's not like gonorrhea or syphilis or something. It has a high barrier, there's a high barrier to the host to infection, but once it happens, there it is.
Cortland?
I've heard that many states are restricting the prescribing to infectious disease physicians or hepatologists.
Yeah.
I think that Oregon was one of those states, and
Yeah.
just wondering your comment on that.
There's a lot of restrictions. So, yeah, so the question is, there's rumor, in fact, there's fact, that there are restrictions being placed on the ability of people to prescribe. One of them is by specialty type. And some places, they don't even let ID docs do it. They just say only hepatologists. And this is a way that they're trying to control cost. Because when they did their actuarial guesses for next year, or when all these drugs came out, they weren't counting on a $90,000 per treatment course thing. So they're trying to funnel it. ID is another group that is sometimes approved, but I'm pushing, as you can tell by my talk, for everyone who feels comfortable ordering the medicines. They should be able to do it. There's no evidence that you need experience or expertise beyond just learning about it to be successful with it, right? Everyone can do this, and so that's starting to fade away. Where they are putting their most restrictions is requiring the patient to have advanced cirrhosis. So if you have somebody who's otherwise asymptomatic and has got F1 fibrosis, which is not much, that's say a kilopascal score of 5.5 or 6, they will not approve the drug without you jumping up and down. So what you can do, scour the patient for whatever symptoms you can come up with. Fatigue. Hell, I'm tired just asking the questions. So, yeah, I'm tired. Okay, they're tired. And sometimes that'll turn the trick. If somebody has renal problems from hepatitis C, cryoglobulinemia, that's almost a medical emergency. They need to be treated now, and when you do, it reverses a lot. Sometimes goes away. So there are lots of other reasons, but you're right. The payers, and I'm sympathetic to them, or empathetic, it's expensive. So I'm putting pressure everywhere I can. I'm putting pressure on the payers to stand up. I'm putting pressure on the pharma companies to drop their prices. But it's chaotic and not easy. And so I think we all should be screaming about that.
So 1 second, Justin, just to be the devil's advocate, I'm trying to get my arms around this prioritization, and that we should take our precious dollar resources and take the sickest people and treat them. It seems like we get more bang for our buck if we treated people early in the course, and then we would guarantee a normal life, etc.
So it depends on which lens you want to look at. Long-term lens, you're correct. Short-term lens, if you prevent somebody from having decompensated liver disease, that's a plus for the short term because they won't come to the hospital with a GI bleed or decompensated disease. But the guidelines were just updated 2 weeks ago to make it even more explicitly clear. Every person with chronic hepatitis C should be treated now, more or less, except if they have a predicted short-term survival from another condition. So somebody has end-stage lung cancer, why are you going to cure their hepatitis C, right? That's kind of common sense, but that's the exception.
In light of the cost information, what's your approach to dealing with patients with ongoing substance abuse issues, questions of compliance?
Yeah, so the question about substance use, and we tend to have a sort of condescending view that you're harming yourself, I'm not going to treat you. The fact is, the evidence is that they do just as well, if not better, than others. There's no evidence that active substance use, like injection, really interferes with success rates. One thing you are concerned about is the reinfection. That would be a problem. So you try to get them into treatment at the same time. And sometimes, if I'm dealing with that, I'll try to coax them into treatment for substance use, and then kind of hold out as a carrot. Well, we'll get you clean for 6 months. We'll do urine drug tests. But that isn't because I'm trying to be judgmental. I'm trying to get them help. But I don't think it's the job of the payer to dictate to me as a provider who I should treat based on substance. Alcohol is another issue, right? Heavy drinking with HCV speeds up progression to cirrhosis enormously. So you want to have them stop drinking, but if I can't get them to do that, getting rid of the HCV will also slow the progression. So, okay. And so I think we shouldn't just have hard and fast rules about that. It should be a clinical judgment and let the provider decide.
I do asthma, or also drug costs are a big deal.
Yeah.
So in these guidelines, and when you're saying that everyone who should be tested, everyone's tested should be treated. In the residence clinic, for example, with 20% self-pay or Medicaid, it seems somewhat ethically precarious to be saying that to someone. You have a disease, I can cure you, but you ain't got no money. No one's gonna pay. So
Yeah.
I'm
Well,
sorry. So is the society
Yeah.
these guidelines taking a position to the pharma companies and saying,
yeah.
this is
So the question is, what about in a residence clinic where there's a lot of inability to pay and some Medicaid? How do we deal with this? It's not fair to say just because you don't have insurance. The fact is, number one, the best place to be if you have hepatitis C is uninsured. Because then you can apply legitimately for compassionate use and they'll provide free drug. So they're our best patients as far as getting access, weirdly. Medicaid, forget about it. You're dealing with the state, you're dealing with limited budget, that's everywhere. I'm from Alabama, so. And, but even for the people who have full pay insurance, you're fighting because it breaks the bank. And to me, the problem is at the level of the pharma company, and it gets really complicated, these pharmaceutical benefit managers, and we could spend a day, but it's complex. It's not a free market, that I can tell you. Not even close.
One more question.
Is there any evidence on the importance of adherence to the regimen and need for adherence enhancements like directly observed therapy?
Questions about adherence, drugs don't work if they're not taken. Period. But what's remarkable, as I said before, all the studies that I showed you are intent to treat. So adherence is factored in. If they didn't take the medicine, it wasn't going to work. Now, what's different about those populations is that those people entering trials are pretty motivated. In the real world, maybe it won't be so much. But so far, the cohort data out of Europe and elsewhere shows relatively the same effect. So I think people taking medicine for 8 to 12 weeks is not such a big deal. Now, Dave will tell us that somebody finishing their amoxicillin for sinusitis, 80% don't make it to the last pill, or whatever the data are. This is different. And in the course of trying to access the medicine, people that hang in there typically take them. And the side effect profile, by definition, for people to take something is pretty good, meaning not many side effects, because nobody wants to take medicine that makes them feel bad.
So, Michael, one last question. So, is there anything we can do to break the logjam? We were all hoping that the free market was going to lead to competition and the prices would come down, as they have with so many other of our therapies.
Yeah.
So, what would happen if just one company, Abbott's drug, gets approved, et cetera, and they undercut everybody else?
It's a good question. I'd love to see the experiment performed. What's happened? I thought AbbVie would do that seriously with their prod, with the one that's on the market. That came in at $84,000. I'm sure some MBA guy in their group figured out, well, we want to maximize our profits and we got to be a little bit below, and they just got too cute with it. And their sales are not that great. I think their sales would have been tons better if they had priced it at $25,000. Then we would have had a game. Then game on, right? And I'm sure they'd be doing a lot better. I'm just guessing. Merck has a chance to do that now, but it's complicated because of the, just briefly, when these drugs get approved, the the benefit managers who try to work out the deals for the Blue Cross Blue Shield and Aetna and everybody else, they go to the pharma and try to negotiate a price, and they do. Sometimes 45, 50%. Two problems. One, that's opaque to us. We don't know what that is. It's considered a company secret. And two, they demand exclusivity, so that your Aetna subscriber has to use this company's product to get that kind of discount. So they force us, by the sort of preferred drug or whatever, to use that product. So if a new drug comes on the market, that PBM deal is still in existence for maybe another year or so. So even if theoretically Merck came out at $10,000, the deal is the deal. It's messed up. Put whatever word you want in for messed up, right?
Okay, so we're going to continue this discussion in conference room B. Mike's going to chat with the residents. Anybody else who wants to join us, feel free. Michael, that was absolutely terrific.
Thank you.